Oopsie. What are we looking for? Is this the wrong one?
No, this is correct, but up there, there's...
Trying to get rid of that.
Trying to get rid of that.
Oh, is it?
Trying to get going.
Presentation.
Well, I have known Jed and his work in the Brentwood group for many years, and I've considered it a great honor to be one of his friends and to admirers. Okay, let's see if we can. Okay. Okay. Learning objectives. One of the things I want to focus on is duration. Nope, I have to use this. The duration of withdrawal symptoms and possibly other adverse effects like hyperalgesia during withdrawal itself, though I haven't studied that at this point in time. A second objective is to learn what it is about studies that have tended to lead to underestimates of what I believe are the true durations of smoking withdrawal symptoms. Then third, I want to discuss briefly relationships of smoking abstinence symptoms, severity and duration with negative affect-related personality traits and with relapse. So a long time ago, one of my colleagues, Saul Schiffman, guesstimated, and he'll admit it was just that from the preliminary evidence at the time, that it took about 10 days for us to get over withdrawal symptoms. And I took that. Most of the field believed that. They were over in 10 days. But then I thought, well, maybe there's a subgroup of people that are self-medicating, and maybe they'll last a little bit longer. So I proposed my first study to NIDA. The first one was called NIDA 1, very creatively. And it was with all males because I didn't know what to do with the female menstrual cycle in terms of what I was about to do. Then the second study was with females once I figured out just get a month-long baseline, and you could get this cycling and study hormones and that sort of thing to see if that was a confounder. So I challenged the field, saying it was 31 days it took to recover, and I'm going to show you some of that data. Then I did another NIDA study, and this was 45 days, and people still did not recover in terms of not only their moods, but also their brain waves. Cognitive performance did not resolve. So then I got yet another NIDA study, which I'll focus on primarily today, which went to 67 days, and the mood data just was published recently for that study. However, recently there was a lit review by Taylor and colleagues that found that everyone felt better within 6 weeks of quitting smoking. And very compelling evidence, and the data that were sampled and reviewed seemed to show that. But that's where my studies have been different, because I believe that experimental work really demonstrating causation needs to have randomly assigned control groups, taking the measures at the same time. I believe this when I designed this study, but lo and behold, I had no idea how important that was going to prove to be in my entire research career. So what's the difference between other studies and those that I've done for the most part? Well, people initially said it was be impossible for me to do my studies, because how can you get people to quit? I said a psychologist should be able to figure this out. So I paid people lots of money to abstain, screened them really well, and got 80% plus people to make it through these studies abstinent. This was my first results I looked at, or a piece of it. And I looked, and I said, I'm a failure. What? This is embarrassing. These measures, with profile and mood states measures, well validated. It's reliable. It says in the manual, everyone knows these measures have been validated by psychologists, and after all, they're the princes of statistics, right? At least in this area. And so I couldn't believe my data. I ended up checking all this data by hand, computer, everywhere I could, subgroups, and this. Let me describe the big picture here. These are 3 weeks prior to people's quitting. In fact, they're 3 weeks. And this is the, and so what happened is, the first time we assessed them, their mean scores on the POMS tension measure were 9. Then they went progressively down to the point where after the 6th measure, they were twice per week for 3 weeks, we had this value around 6. So now they've gone down by 50%, or by at least 1/3, another way of looking at it. Then, of course, they quit smoking. Their tension rose, just like we assumed it would. But let's see what the literature would have done. The typical literature using one data point for baseline, and assuming it's stable because the measure is reliable. I would have interpreted this, and the literature generally interprets this as, well, the person has an increase in negative affect, and then within a week or so is back below where they were before. But they didn't take into account the testing effect. That is pervasive in this area of psychology. Very few psychologists know. There are a lot more learning about it because I've been preaching about it for quite a few years now. So this downward effect is not a treatment effect. This is mean baseline values. This is not regression towards the mean. And I found this over and over. And so when we use the mean of these last 2 days, a baseline pre-quit, you elevate and never recover in 31 days to baseline levels. I found this for a lot of other measures, but this one is just one I happen to have that was especially relevant. Therefore, in my analysis of that entire first study, I subtracted out from my change scores the mean of the last 2 baseline sessions. And what happens is we had a randomized control group that kept smoking, something never been done before also. So we had a long baseline, and we randomized people to quit or not quit. How can you ethically do that? Well, we call them delayed quitters. We're going to pay you to quit after the 31 days. We're going to pay you a little bit extra to keep smoking and then quit. And so you still get your quitting in. Tension, they never recovered. Maybe a slight tendency, but it looks like it's kind of asymptoting out the difference. Look at anger. No even tendency. And you can understand, when I first saw my data, I found it difficult to believe. I believed 10-day resolution. Maybe a few people neurotics would not resolve, and I saw this bizarre thing happen at baseline. I saw no convergent after 31 days. So when I discovered this testing effect, which was very distressing, I looked throughout the literature, and I only could find a few examples of it, but a study done on undergraduates by Ahava et al. Found the same exact thing. So I said, oh, Carbondale, Illinois is not some strange place in the world. And Ahava used the Beck Depression Inventory, 7 administrations weekly over an 8-week period, and found a 40% decrease. Here's their values. It looked almost exactly to what I had found. There's no intervention. They're showing up, taking the BDI, coming back a week later, taking it again, and look at the scores. It looks just like the effects of cognitive behavioral therapy in a cognitive behavioral therapy book I happen to own. Here's our data from NIDA 2. Now this study was all female until we wanted to have 5 weeks of pre-quit baseline assessing mood twice per week. And you can see this downward drift, just like we'd found before in the BDI, in this case. We also did correlations, test-retest correlations between the first data point and subsequent ones. They tended to be about 0.70 across time, even though the score was going down. So this struck me, I looked in manuals. They defined reliability in one way, correlations. Okay, it's the wrong way. So if you believe any manual that I've yet found, I've never seen one looked at mean value stability or reliability. They've looked at correlation, so you could drop from 100 to 1, or very low scores, and still have a 1.0 correlation. Because if the rank order stays the same for everything, you could divide it, multiply it, whatever you want. This next taking, if the rank order of the individual stays the same, the correlation will remain 1.0. Here's our second NIDA study. These are our 5 baseline weeks. We are assessing them twice per week, so these are the means of each of those sessions. We had the group that would quit, the dark circles, black circles, and then when they quit, their scores went up for the profile of mood states, and it stayed flat pretty much for the delayed quit group. But once again, we had this downward drift in negative affect-related scores, not only for POMS tension, POMS anger, like we saw before, POMS fatigue, BDI, depression. It's a pervasive fact. Ahava showed it, and a half dozen other people, not in substance abuse literature, but I've persistently found it, and found it to challenge our thinking. Now, look, they aren't returning. Look, there's after 31 days. So that was NIDA 2, looking at females. We also looked at EEG. We're looking at, in this case, delta power, which is very slow. EEG indicative of drowsiness. Well, we found similar traits with theta and alpha. When they quit, there's an increase in the quit group in terms of the amount of power, brainwave or EEG power, relative to the control group and relative to baseline, both with eyes opened and with eyes closed. So just, and no tendency to resolve across 31 days. So we have self-report not resolving. We have the EEG data not resolving. And in this particular study, we had data showing that cognitive performance also decreased and stayed that way for 31 days of abstinence. So there's design limitations, just in summary of what I've been saying in other studies. They haven't randomly assigned people to quit or not, whereas we had randomly assigned controls to control for testing effects. Another thing about studies, including mine to some extent, that bias study results in terms of the negative one, the darkness of abstinence phenomena, is those individuals who experience the most intense withdrawal symptoms, they relapse back to smoking or to substance abuse, whatever it is. They are not included in the sample that's analyzed. Therefore, it looks like the severity of withdrawal symptoms is less that in fact would be, because those with the most severe, obviously if you went to excruciating pain, you'd drop out of the study, right? With withdrawal, if everyone did. Or everyone turned green, you would quit. So it's biased, even our study. So we did have some withdrawal, some dropout, even though it was less than other studies, because we paid people lots of money to stay with us. And also probably individuals with traits like we've talked about, individuals with pain, I don't have it listed here, but with depression, neuroticism, these personality traits, those individuals tend to drop out of studies. Those individuals also tend to experience greater severity of their withdrawal symptoms, even in retained samples. So once again, withdrawal symptoms may be a much worse culprit than the field generally gives them credit for being. Okay. Now on to the most recently published study and to results I got literally yesterday morning, some of them. This is the title of the study. We're looking using multiple modes to assess people, including mood, brain waves, evoked potentials, and so forth. And these are our inclusion and exclusion criteria. We had roughly 30 people or so in each of the, I'm looking at the wrong thing here, 30 or so people in the each of the groups that were randomly assigned to one of 4 groups, to a delayed quick control, just like we had in our previous studies, to a placebo patch condition, or to a bupropion group, or nicotine replacement patch condition, all double-blind. That comes standard measures of withdrawal symptoms and EEG recordings, which I'll present a tad bit of today. Those are the things I got yesterday. So here's our design. First we had a pre-quit phase and then a post-quit phase. The pre-quit phase had 2 parts. We had adaptation sessions initially where we practiced the task and practiced even having an EEG recording, stabilize any drift. Then we took mood samples and EEG samples, ERP samples, before they were on any medication. So this is like our baseline day. They're still smoking. Then, because with bupropion, you have to take it for 14 days before you make your quit effort, we did that. We randomly assigned our people to continue smoking during the 14-day period, and only the group that would eventually be on bupropion had active bupropion pills. The other 3 groups were on placebo capsules for those 14 days. Then we took a second EEG mood, etc. sample here. We also had a number of samples of mood during this pre-quit phase. Then we had a post-quit phase, and we analyzed brain waves and so forth and gave the drugs. At the very end, they were off of medication, and that's something that may prove to be interesting to look at in the future. But we gave them $700 to maintain abstinence, and a little bit more than 2/3 of them maintained abstinence during that period of time. We verified that the quitters, and what I'm focusing on here is the placebo group of quitters versus the control group of smokers here in this study, even though I have the data from all 4 groups here. And you can see this is a negative mood score, Z-score transformations. So this is baseline across the first 4 points. And then what happened is the groups who actually quit had increases in negative affect. So you could see placebos up here, they had a slightly larger increase in total negative affect. But look what happened to your smoker group. And this is across 67 days. Look at this. In 67 days, no tendency to resolve. 0. Anger, same story. No tendency to resolve. These are randomly assigned to treatment group, including the smoking delayed quick control group down at the bottom. And their scores keep going down, notice. The control group, this testing effect, these people are doing the same thing the whole time. They're just smoking. And you ask them, how angry are you? And they say, day by day. I guess life, I'm getting mellower as I get older. Maybe every day I get a little bit less angry, a little bit less negative. I think there's a itty bit of truth to that, but I don't think it's happening at this time scale. So highly significant effects, and you can see at the last couple of weeks, they are totally off a treatment, but that didn't seem to influence too much of things. It looks like nicotine patch decreased negative affect, just kind of borderline early on, but didn't have any lasting effects. Of course, we down the dose was downed after 24 days and then downed again through 45, and then they're off patch. But the important big picture is here, these people aren't resolving. Another part of the big picture is they're 0.5 standard deviations below the mean as a group of where they started out at. So these aren't trivial, like 0.1% or a tenth of a standard deviation. These are half of a full z-score difference. So that's quite a difference. It reminds me of my colleague who smoked, and he said, when I smoked, this reminds me of Olivier too. When I smoked, my wife said I got meaner, and I stayed that way. Was his quote. And he was honestly a believer. He was not a smoker anymore, but he just felt chronically more irritable. I'm not saying that's the case necessarily, but look at craving. Now, on the other hand, there's some positive news about craving from the same study. And with craving, the smoking group up here, the gray group here, they also decrease across. There's a testing effect also for craving, and probably and also for trait measures. There's a lot of negative affect measures, by the way. So if you give the Neopie twice, the mean score for neuroticism and most of the negative affect scores will decrease significantly. And everything else we've tested almost has this effect. It's a very pervasive. But the good news is that after about a month, quitters experience much less craving than even ongoing smokers. So they had an elevation initially above the people who kept smoking, and then it died out. And that replicates previous research. That doesn't have randomized controls, but at least it replicates it and says, okay, that's true. And we found that in all of our studies where we had randomized no-quit controls, multiple baselines, and we're able to more accurately, I believe, and John Hughes, who was a researcher I greatly respect out of Vermont, he read my article that I'm depicting here, the pieces of, and said, I've convinced him of the validity of what I'm showing you here today. Now, this is the stuff I analyzed yesterday before I rushed off to the airport. And I have tons of EEG data. But here you can see we had the placebo quitters, and they had a great increase in alpha 1 power. That's low alpha frequency at both 3 days and 67 days. No significant tendency for the brain waves to normalize after 67 days. Just like in our previous NIDA studies, no tendency for them to normalize. Rapid visual information processing. So there's very few studies like this because maybe very few people are willing to put the huge amount of effort and to pull it off, but this is telling us an important story. We're going to have much more interesting data when we do some of our tomographic analysis of EEG and ERP on this, but I also found this for delta the night before, and for theta, the same pattern, which is replicating what we've seen in earlier studies of 45 days and 31 days. So I think it's a very compelling story. It's relevant not just to substance abuse, but I've had psychologists from all around the world say, isn't this incredibly important? I say, well, I could say yes as a clinical psychologist, because a lot of what we think we're seeing without control groups isn't what's really happening, and I honestly believe that. And so I'm going to now this is very, I don't know how I am doing with time here, but go over this quickly. This is a very complex write out of the article. I'm sorry that it's so messy, but what we're looking at here is traits, how personality traits from the NeoPi correlate with smoking abstinence symptoms. There's 4 types of negative affect-related abstinence symptoms: anger, anxiety, depression, and the total negative affect score, the PANIS. Then we have a positive affect score and craving score from other indices. So we had traits correlating with states at different points in time. Virtually no correlations other than with craving and these personality traits at day 3 of abstinence. So at day 67, however, you have quite a few significant correlations between the states and the smoking abstinence, or rather the traits, personality traits, and the smoking abstinence symptom severity measures. Interestingly, if you look down here at the bottom, the FTND at the lower left doesn't correlate with much of anything in terms of withdrawal symptom severity, including craving in my study here. Now, this was done with the full sample of quitters in this study. So these were partial correlations controlling for whether or not you're in a bupropion group, nicotine replacement group, or the double placebo group. I had to do that to get adequate power to test this. One other study, NIDA 3, if you will, on my list of things, is a study in which we assessed relapse as a function of withdrawal symptoms. So let's focus over here on the right. And you could see that there's 2 groups. There's a group that relapsed within a year, and a group that was abstinent at the end of 1 year. And you could see the group that was abstinent, after 1 year, they had a lot lower withdrawal symptoms after 45 days of abstinence. And this was enforced, validated, all these studies, biochemically validated with cotinine every 12 to 48 hours, and at the longest a week. So this, we really know what's happening here. So those with fewer symptoms, and there were contingencies for maintaining abstinence in this particular study for 45 days. Then the contingencies went off, and people started to relapse more rapidly, of course. We assessed them at different time points, 3, 6, 9, and 12 points after quitting, and we could predict relapse as a function of severity after 2 months plus of abstinence. In fact, it was that was strongest. The later you went out in time, the stronger the prediction was. Because if at the beginning there wasn't any association between relapse and early, it was later relapse. So what might this reflect? It could reflect unmasking of psychopathology, of pain, who knows what, that's inherently occurring in the person. That in this group, you might hypothesize the group with less tension, anxiety, and other negative affects. Maybe these were the low pain people as well. We'll have to go back and take a look after this conference. And we found the same thing after 3 months. So that's all this is showing. But it also reminds me of something that Jed Rose does in some of his research. What he does is he gives people a nicotine patch and sees if people decrease their carbon monoxide concentrations, and then bases treatment based on that. Well, you could base treatment on whether or not the person has returned to their baseline value. Those who return to below baseline values, they're going to be more likely to be abstinent. Those who fail to are more likely to relapse. And remember, these curves are not including the fact that what? There's the testing effect. With the testing effect, if you put that correction in, this group of relapsers would have had a much greater elevation of their scores. So in conclusion, smoking abstinence symptoms last a lot longer than I ever dreamt they did. However, like I dreamt a long time ago, maybe neurotics and depressed and those populations actually have more severe symptoms, and they weren't included in the samples because they dropped out. Well, they do that, but I tried to rectify that by paying people more money to stay in the study irrespective of that. It didn't succeed entirely, but I have reason to believe that I largely eliminated that problem. What are the implications of long-duration withdrawal symptoms? Well, obviously interventions of various sorts, maybe prolonged pharmacological treatments or other treatments. And what does it say about our models of abstinence symptoms themselves? As I mentioned before, is it really just the unmasking, a psychopathology? And is the motivation for much of smoking a self-medication model? Does nicotine do irreversible damage somehow? We don't know what this is. It could be genetic factors, most likely a combination of all the above, as we guess from the complexity of human behavior. But it's possible that, and some of the animal evidence suggests that chronic nicotine can do damage that may be irreversible, at least not reversible in 67 days. I would love to do a study that went out to 120 days. I proposed that tonight, and they thought it was too long. Then I reduced it to 100 days. They said that's not different enough from your 67-day study. So let me say the exact number of days, it should be 110, I guess, for if I resubmit it. And then finally, we showed that smoking abstinence symptoms, the severity of them is related to relapse, and negative affect traits are related to all the above. Any final questions?
We can start a couple of questions specifically, if you have any questions for Dr. Gilbert, and then we'll merge into a little general discussion.
You mentioned as you were talking about age, did age play any role in your studies? And did you, about...
We've only had modest-sized sample, and we generally haven't found age to influence much. We didn't, also in the one study with hormones, I did a lot of precautions and expectations that, you know, mood's going to follow menstrual cycles, going to be sampled, where people were in their cycle, took hormones and so forth, and we didn't find that. But once again, only very small to modest sized samples, because these are very expensive studies and they take a lot of work to run. But I expect that age would. I have some proposals in tonight looking at galantamine, which has some similarities to nicotine, and combining it with nicotine patch, which I'm very excited about. That is a possibility for middle-aged and older individuals.
You said there weren't any effects of the hormone fluctuations. What about separating out women who were taking oral contraceptives versus not?
Yeah, we assessed that also when they were taking them, and once again, power limitations with a study like this, different conditions. We didn't find anything to our surprise because we put a lot of effort into that. We were monitoring people weekly, doing blood samples for, you know, absolute quantitative measures of hormones and all that, but we didn't find anything, which surprised me. But once again, I think it's probably due to just moderate sample size. You get a couple of outliers in a modest sample size, plus your group's divided up between naturally cycling people and on different types of oral contraceptives, and so the samples can get very small and unreliable.
Okay, interesting talk. I was just wondering if your data might suggest that some of the symptoms of withdrawal are actually not withdrawal symptoms, if it's more of an offset effect, where you have a unidirectional change that doesn't reverse.
Right. I think that's something I should have emphasized more. I think that that's almost certainly part of it, because we know that people are higher in psychopathology, smokers that is. We know that if you look at the matrix of information and correlations out there, people who are more impulsive and depressed tend to have deactivate brain activity in different spots, and nicotine activates those things and tend to have these antidepressant effects, concentration enhancing effects. So it seems that people almost certainly, especially as we had the prevalence of smoking decrease, I think there's people who have argued that the concentration of smoking is in groups with much greater psychopathology needing some sort of self-medication.
So I think that leads then into the natural question that sometimes people use as a control group non-smokers or never smokers.
Right.
So like, for example, with your alpha power or any of the brainwave measures, were the smokers to start with, did they look like normal non-smokers, or were they actually enhanced in their performance compared to a normal non-smoker?
Generally, as you well know, there's lots of confounds, you know, like a research, I mean, the faculty during dissertations and theses will say, you got to have a group of non-smokers to see if they're different or if it's a true effect. And I said, no, these aren't randomly assigned to being a smoker and a non-smoker. They're genetically different. We know that. We know a lot of the genes relate to things that we're interested in. And it's going to be a total confound. Your ideal control group is not an ideal control group. I'm preaching to the choir here, I think. Did I miss what you're...
No, I know there's problems with that control
but
group, but...
They're
yeah.
closer. Oftentimes they're still slightly suboptimal after they smoke, but sometimes we'll find them to be the same. But we I haven't run non-smokers much. A few pilot tests, but others have done that sort of thing, and they typically are almost as good while smoking, but when they quit smoking, individuals deteriorate.
So maybe it would be like NIDA's ABC study or something that's a true longitudinal study that follows kids before they take up smoking or other nicotine.
I think the ABC study will be fantastic for this. If we could just get them to randomize their kids to different substance abuses would be
That might be difficult. So, we have a few minutes for general discussion. Thanks again,
Okay,
David.
thank you.
That was great. Any sort of general comments or questions on the morning session? Oh, yes.
Yeah, I think moving forward on especially on the clinical side, on this issue of pain and smoking and dependence and predictability, we'll probably need to think about a more systematic approach how to to assess that. In terms, for example, in the chronic pain assessment in patients, there's more and more now thinking and emphasis on the QST measures, for example, the quantitative sensory testing to get a baseline before, and then after that see how these sensory testing, which has very high reliability in animal models too, so we can make that bridge. The other thing is maybe some of these biomarkers of inflammation, in the blood, that we can also easily do in the animal models, and we could do more. We can do neuroinflammation, which is not easy to do in human. So to get a clearer idea on, what's happening and is it really pain? The whole business of pain inventory, or scales, there's so many of those. That's something maybe the field needs to think about, how to assess a baseline, pain scores, and what scales need to be used, and throughout the things. I mean, David studies, it's great to have this longitudinal, long-term, but I wish there was a more specific pain items, so we can, maybe in NIDA 8 or NIDA 9.
General comment on the morning session is that it was awesome. For me, one of the things that would be a really big enchilada would be leveraging what we know about nicotinic receptors and smoking and pain to come up with new medications that are clinically effective analgesics to address the huge opioid use problem. Now, what Ahmad said was that Abbott had a failure, and they were focusing on alpha-4 beta-2. And the failure was because people vomited and, non-compliance and all that other stuff. And so now it seems like the big targets are alpha-5 and alpha-6. So my question is, thinking in terms of medication development, is it really alpha-5 and alpha-6 that we want, or do we want to reduce the untoward side effects of the Abbott compounds that were alpha-4 beta-2 targeted?
Good question.
I'm going to give it as you try. So I personally, I think there may be some tweaking to do on these alpha-4 beta-2 subtypes, targeting alpha-5, maybe alpha-7. But my work is now focusing more on alpha-7, because alpha-7 are part of an endogenous anti-inflammatory system mediated by the vagus nerves. So there's a clear evidence for it in human and animal studies. And there's multiple alpha-7 ligands now, direct agonist, partial agonist, PAM, positive allosteric modulators, both in phase 1 till phase 3 for multiple cognitive and schizophrenia type. Most of them failed, but none of them has been trying to pain. And that's really, it's just the low-hanging fruits. The other things, we recently published a paper where we show, and Darlene Bronzell and others, that alpha-7 agonist reduces nicotine self-administration and reinforcement. And in our hand, it also reduces some nicotine withdrawal sites. So there's a lot of component, Ken Perkins did one study on an alpha-7 PAM, but that was a week PAM, one dose, and we failed to see changes in the smoking cessation. But I agree that that's a target to go after the nicotinic receptors and pain. Yeah, varenicline was shown in animal models to have analgesic properties type. They were not mediated by alpha-4 beta-2. Surprisingly, in our hand, is mediated by alpha-3 beta-4. So, don't know.
Yeah, I had a practical question in terms of, you know, there are these drugs under development and being tested, but there is a drug treatment out there, nicotine patches. And I'm just wondering, in terms of smokers who, say, undergo surgery, and so naturally they can't engage in their continued addiction while they're patients in the hospital, and immediately after surgery, and it's well documented that there's a hyperalgesic effect with smoking cessation and withdrawal. What about simply providing nicotine skin patches for smokers as they come out of surgery? Would that reduce their need for so much of the opioid analgesics?
The problem is the status.
Is what?
The status of the patients, you know, for smokers or former smokers, there seems to be the opposite effect, hyperalgesia.
If you get nicotine replacement, you get hyperalgesia?
Mm-hmm. If you're a smoker or former smoker, depending on the length of abstinence.
Oh.
So that's one thing that you need to be aware of.
Interesting. Okay.
I think that's true, and nicotine patches are now routinely available to smokers on inpatient units across the hospitals.
Okay.
So that's
so is the experience that if they're given patches, then they require more or less analgesic, opioid analgesic?
My understanding is it's a small effect. Like
It's a small effect. It was done in an intranasal nicotine.
I see. Okay.
This question's for you, Jed. In terms of your sensory stimulation in the lungs in particular, and then the vagal stimulation we heard of before, mediating potentially some of the analgesic effects in these models. Have you studied or know of anyone who studied just, what was the name, Zinzer or whatever it was, the stimulation, inhaling like citric acid or something like this, stimulating your vagus receptors in the lungs?
Well, so yeah, there was Heinz Ginzel was a researcher who studied cats and showing that nicotinic agonists injected into the right heart produced an immediate skeletal muscle relaxation response even before nicotine got to the brain. And he thought, I think it was sebacylcholine was what he suggested would be a nice cigarette substitute. It would be a cholinergic nicotinic agonist, but it would be immediately broken down in the bloodstream by pseudocholinesterase, so it wouldn't have any central effects. That was his suggestion back in the 1970s, and I don't think anybody's ever tried it.
But I thought you'd done some, well, I know you've done some stuff with sensory impact, and I was thinking about the vagal impact of that and whether that might modulate pain.
Well, so yeah, we've done a lot of studies over the years with inhaled citric acid, ascorbic acid, capsaicin in very, very low concentrations, oil of black pepper, I mean, you name it. And actually the FDA made us stop because, you know, as we now know, generally recognized as safe food ingredients are not grass when you inhale them. And so, so we kind of had to stop that, but then we turned to nicotine, of course, and developed various ways of inhaling nicotine, which does stimulate these lung receptors, and it's part of the pleasure of smoking. But we have never looked at the effects on pain of, let's say, a peripherally acting sensory cue, whether it's citric acid or the nicotine pyrrolidine methiodide that Ozur DeCordy used in that collaborative research, but I would love to do that. Well, I think it is now lunchtime. If You want to go out to the right, one or two doors, I'm not sure, but the herd will find the way. And then we'll reconvene in, what is it, at 1:30.